hospitalization reduction and vaccination increase best practice calls. These slides will be available on the IPRO Learn website in 1 week time. So if there's anything that you want to look at after the presentation, it will be there for you to see. Next slide. So for today's agenda, we're going to go over some meeting minders. We're going to talk about some of the hospitalization interventions that the network has introduced and some of our resources. And then we're going to have a guest speaker, and then we're going to do the same for vaccinations, talk about vaccination interventions, and then have a guest speaker and some closing remarks. Next slide. So for the meeting minders, basically we ask everyone to please mute your line, do not put us on hold, be present and engaged, and participants are encouraged to utilize chat to ask questions and make sure the comments go to everyone so that everyone can see yours. If it's a personal question, you can do so, address it to the person you want it to go to, but for everyone to see, we like you to use everyone. And please do ask questions. All meeting materials will be available on IPRO Learn or the network program website. Next slide. Next slide. Next, okay. So the objections for this program are basically stating the CMS goals for hospitalization and COVID-19 hospitalization reduction, list the CMS goals for COVID, influenza, pneumococcal vaccine, educate your team on tools and resources to assist in preventative infection control measures, and list the reasons for bidirectional communication between care partners, as it is important to ensure quality patient care and to build up a plan to uptake in vaccinations. Next slide. So my name is Deb DeWalt, and I'm just going to briefly go over the overarching goals of this project and share some resources. Next slide. For this project, the hospitalizations, readmissions, and 30 emergency room visit reduction project, there's 3 goals. 1, to reduce hospitalizations, 1, to reduce unplanned readmissions, and 1, to reduce ED visits. The 5-year overarching goal is a 20% decrease. The source of the data for this project comes from Medicare claims data from the hospitals. And this year, the goal was to decrease each network's metrics by 5%, with an overall goal of 2% from last year and 5% from this year, for a total of 7%, which is slowly increasing until we increase to that 20% reduction. All of our primary diagnosis codes for the project are listed below. 2 of these are our speaker specialty, vascular access infections and clotted accesses. These primary diagnosis codes are tagged by CMS as being some of the most frequent that patients enter into the hospital with for vascular access. Next slide. So how our work is directed is that every network has an advisory committee. Our speaker today is a member of the IPRO ESRD Hospitalization Reduction Advisory Committee, and the advisory committee suggests and provides information and input to the networks so that we can trickle down their wisdom to our community coalitions. We've had 3 community coalitions, and the 3rd one is shortly closing, and they will enter into a community of practice that we are building with people who we've provided tools to help them reduce hospitalizations. And ultimately, all of these folks working together are improving the quality of patient care. Next slide. IPRO has put together many tools. We do have a hospitalization reduction toolkit on the IPRO website, as well as on our IPRO Learn. I just want to remind everyone that IPRO Learn, the site has moved, but the login remains the same. If you do log in using the old login, it will redirect you to this IPRO Learn URL. So some of the things that we have created based on root cause analyses and suggestions from our previous community coalitions is a Transitions Champion interview checklist, which helps facilities collect the correct information and do adequate medication reconciliation and follow-up care with the patient after they return from the hospital. Another is a resource we created calling Don't Miss a Minute, which is very much related to the increase in fluids and mistreatments that often lead to ER visits and an acute dialysis treatment in the house. Other transitions materials that we have released are the ESRD forums, Transition of Care Toolkit with special attention to Chapter 8, and a shorter version of a toolkit and or change packet from the NCC on strategies to reduce hospitalizations. I think you'd find both of these very helpful if you're looking for a way to launch your project. Next slide. Our next speaker, and I'm very happy she's here, is Dr. Tia Durescu, and she received her MD from New York University School of Medicine and completed her general and vascular surgery residencies at Mount Sinai Medical Center. And while she was there participating in a general surgery training, she did a year of research in the divisions of liver transplant and vascular surgery. From 1992 to 1998, Dr. Tia Durescu was chief of vascular surgery at the Bronx VA Medical Center, where she instituted a diabetic foot clinic in cooperation with podiatry and endocrinology to combat emergency amputations for foot infection. During this time, after 1998, she joined vascular surgery faculty at Mount Sinai Medical Center and served as a medical director of the vascular laboratory from 1998 through 2003. In 2010, Dr. Tia Durescu received a Master of Business Administration in Healthcare from George Washington University, and she was a member of the Fistula First Catheter Last Workgroup Coalition, helping to create various tools for both dialysis patients and the professionals who care for them. So she's a member of the Look, Listen, and Feel initiative, and that was a great one. Dr. Tia Durescu was named to the Divisional and Medical Review Boards of Network 6 after she landed in Georgia, and Dr. Tia Durescu is also an active member of the IPRO ESRD Hospital Reduction Advisory Committee, and it is my honor and privilege to present to you Dr. Tia Durescu. Next slide. She needs to be unmuted.
Okay, can you hear me now?
Yes, we can. Thank you.
Thank you. Even after all this time on Zoom, I'm still not 100% comfortable with the mute and unmute part of it. But in any case, I'm very happy to be here. This actually describes things we've been working on really over the last 2 years. And it began primarily with the origin of COVID, because it interfered so much with our ability to take care of patients. During that time, even at the onset, we had always thought that access was not elective but emergent, and so we never really stopped operating on that. But it was still difficult to get people to want to come into the hospital or into our office because there was so much unknown about COVID at the time. What we realize, and I think this goes back to the origin of medical education, that we are all taught in silos and we all separate into groups of types of clinicians. And that's especially true in access care, where there are people in the dialysis unit, the access surgeons or interventionalists, the patients, and the nephrologist, and we all live in our own world, and that leads to, I think, some maybe miscommunication. You know, one prominent nephrologist actually said to me at some point, Vicki, you don't realize that you surgeons are actually the enemy, and it's like, why would you say that? And it's like, well, I think because it's, you know, kind of how we think as well. How come the nephrologist can't get the patients on dialysis sooner? How come they can't figure that out? Why are the people in the dialysis unit always having difficulty with my accesses that I struggle so much with? And I'm sure there are comments about surgeons and other interventionalists doing too many procedures on patients, and I think each of those aspects really crystallizes how difficult this whole matter is. You know, that it's hard to know about who should be on dialysis. It's very difficult to create an access, and it's difficult to do perfect cannulations and get things to work, especially if they may be slowly breaking down. So how do we get over this separation? And because Zoom had been a thing in the initial thing of COVID, we had the idea that we could actually do telehealth visits with the patient in dialysis. And that turned out to be a completely lovely and wonderful thing, because first of all, patients don't always want to come to my office on their off dialysis days. When they do show up, I would say, why are you here? And it's like, I don't know, they sent me some problem that may be difficult to track down dialysis staff to see what the issue is. But during these visits that take place with the patient in dialysis, with dialysis staff there, and with the interventionalist and sometimes, you know, the nephrologist, everybody can talk about their points of view. And the patient sitting there listening to all of this and take away from it a realization that access really is a big deal. It's something I need to pay attention to. Look at all of these people paying so much attention and worried about it. Then it just leads to better communication and I think better understanding of each other's problems and difficulties with maintaining good access. We have developed some protocols so that we can go through visits quite quickly and everybody's involved, and we're hoping, we were hoping that early that this sort of intervention could actually increase access to care, cut down on the no-show rate, and by early attention to access, reduce the hospitalizations and ER visits because we're proactively monitoring the access before problems develop. Next slide. So we have 4 outpatient dialysis facilities here at Emory. There's about 700 patients in them. There are 8 different hospitals in the system, so we're all over Atlanta. our staff, actually our access experts, can rotate and visit each of the dialysis facilities, so it's more person-dependent rather than facility-dependent. And what we really rely on is not only their knowledge, but the ability to evaluate accesses using a handheld ultrasound. This did involve training frontline staff with ultrasound. Not only do they use it for telehealth, but it's also been invaluable for cannulation of difficult sites. And because the master cannulators are able to rotate through all the facilities, this information is readily available. We just use the standard either iPads or iPhones for the visit itself. Next slide. So here's one of the plans that we had. If a fistula was created, normally we had done 2 visits, a 2-week visit just to check the wound and the fistula maturation. We still do that visit in person, primarily because we like to feel the fistula and make an instant assessment at 2 weeks' time, whether we think the fistula has a good likelihood to go on to mature or if we think there will be a problem with it. And we try to discipline ourselves that if we think there's a problem at that 2-week visit, to take some sort of action to prevent the patient staying with the perm cath for a while. If we think the fistula has a good likely chance to mature, the patient then goes back to the dialysis staff who continue to watch it. I don't want to say kind of for us, but no, it's really for the patient. And then when the dialysis staff thinks that the fistula is ready to mature, we do a telehealth visit. And this is very excellent information because it tells me right off the bat that people who are the most expert at cannulation and really are the ones who actually know about whether the fistula can be cannulated or who are doing the initial assessment, and that's just assisted by information that we gather by use of the ultrasound. This is a direct communication and completely eliminates the need for the patient to have to remember what's going on or pick up on what they think is important about their care. The other thing actually is that it eliminates the need for the patient on an off-dialysis day to come into the office. And here in Atlanta, transportation is a very big deal. And not having access to good transportation, or now with gas prices high, people don't always have the wherewithal to come into the office, and you really don't want them to miss this visit where the fistula can be cannulated. Next slide, please. And so here's kind of the setup. This is a picture of our ultrasound. And it's perfectly capable of doing everything that we like. And it was relatively, I think, about $2,000, so cost effective for the information it gives. Next slide. And here's some information. Our protocol for looking at ultrasounds is just a simple mark off 2, 4, and 6 centimeters on the anastomosis. The tech sonographer shows us the fistula at those sites, primarily with B mode. Next slide. And this is a picture we get where the tech is able to measure the fistula and also measure the depth. So we can tell just by looking at this, the fistula is a good size, superficial enough, things look great. Next slide. And we also have the capability of color flow. And this is actually important. We don't do velocity measurements or get into the fancier things of ultrasound, but to be able to see the fistula completely fill with color says to me that there are no stenoses, there's no clots, there's nothing in the fistula other than blood. This looks like it's ready to go. So this particular patient actually had a question of high venous pressures. And so we looked at the ultrasound primarily to see was that occurring within the fistula itself or a more central problem. And in evaluating the access, the fistula looked pretty perfect. So just with a quick 5-minute thing, this is it's more likely a central venous problem. The patient was scheduled for a fistulogram at that same setting. And so it skips the office visit, it skips any diagnostic studies, I think, to get in the office, and the patient just goes really right from the dialysis chair to fistulogram with a targeted, most importantly, a targeted view by, in the surgeon's mind, or what are we looking for? So we're not messing around with anything other than this is central disease, let's just go right there. Next slide. So we've been using this. The best thing right off the bat is that patients are actually pretty ecstatic about it. It's so nice to be able to reduce our outpatient appointments. It's so nice to have face-to-face talks with everybody involved, and with a good understanding, both in the dialysis staff, in the surgeon's office, and with the patient of what the issue is and how are we going to solve it. And actually the patients are always kind of happy to sort of see us. And it strengthens the view that we're there to help them and then try to make their lives as easy as we can. So primarily, I think the most important thing is improve patient satisfaction. We're looking to expand this currently with other quality improvement projects, because we think from this what we can develop at the dialysis facility is very focused, very direct. How do we proactively maintain that access without just responding to when things happen? And I think that if we can get to that point, ER visits should definitely drop. I think next slide, although that may be the end. Okay, so here's a part of our next thing is that we, a while back, we have been worried about ulcerated or aneurysmal fistulas. And there's not much, I think, in terms of good knowledge of what do these things do. Some people say okay to just watch them, or don't cannulate where the ulcers are. Some may end up healing, some may end up progressing, some may end up exsanguinating. And so this next step is that we, in one of our units closer to my particular hospital, and we have taken pictures of every single access. And actually this afternoon, what we're going to do is have everybody involved, vascular surgeons, nephrologists, interventional radiologists, and dialysis staff, look at all these pictures together and evaluate them using this scale. This will validate the scale so that if somebody says, this is on the higher end, we all understand that, yes, that's a problem. We hope to repeat this process every 3 to 6 months in an effort to give us a much better idea of what happens with ulcerations and what happens with aneurysms. I know the common knowledge with eschars and ulcerations is just cannulate around them, but we really don't know if that's enough. And we're hoping that taking this close drilling down on it view will give us a better answer. Next slide. So that's where we are right now with this project. And I'm open to any questions. I see one about how long does it take to complete. The ultrasound is actually pretty quick because you can just slide the ultrasound up the arm and take a few measurements. I would say it's about 10 or 15 minutes. Obviously, the more comfortable people become with ultrasound, the quicker that is, but it's a relatively short thing.
I just see one comment that says, this is amazing, and this is just at Emory, but they wanted to know if it could be expanded to their area, and who to get in touch with, and I could give them contact information.
Yes, absolutely. And actually, in my wildest dreams, I think, well, there may be people in more rural areas who would like to have, what's your opinion of this? If there's a telephone, then this process, things can be looked at even by people, 100 miles away, or just think about things. We're doing this here at Emory because we've been working on a very strong collaboration between vascular nephrology and IR, as well as the dialysis staff, and we're very lucky to have this close collaboration. But I think this is something that all patients would benefit, and I think the main thing is to get out of the mind thought that I'm the vascular surgeon, I'm not going to think about anything else other than that, or everybody else's point of view. So the ultrasound machine, so it's primarily for difficult cannulations, I think, or where there's any question, and actually, there have been one patient, we didn't have those pictures, but the staff brought it to us, and they said, look at this fistula. You can cannulate it here, but then they went and got the ultrasound and said, look at it up here. This is a cephalic, upper arm cephalic fistula, where the fistula was 2 centimeters deep, and so there wasn't enough length of fistula to easily cannulate, and dialysis staff had gotten the idea, if I'll just show them with ultrasound and then we'll see, and that patient went to have the fistula superficialized pretty quickly after that visit, and so I think that was a save. If we didn't have this method, there may have been persistent cannulation of a very short segment, or attempted cannulation where the fistula was too deep, and then injury to the fistula, getting clots out or pseudoaneurysms or something. And so this kind of really focused approach that anatomy really does matter in terms of access. It's helpful for everybody to have this.
So Dr.
We have techs doing it. We have RNs doing it. There's some now through ASDN. I think we're starting to work on competency training, but this is a very simplistic thing that I think you don't necessarily need competency training after it. If somebody who's trained in ultrasound looks at the images, I think that in and of itself is good quality control to saying, yes, your images are good, and I can figure out what you're telling me based on your ultrasound, or I can't see a thing, you know, I'm just going to have to do something else.
Dr. Henner from Network One would like to know, do you use the ultrasound for all cannulations or just difficult cannulations, or how do you decide when to use an ultrasound to guide?
And so it's more for the difficult cannulations. And, you know, there are some fistulas that are very nice and superficial, and, you know, I don't think that you need to have ultrasound for that. And so it's more for the difficult ones. And then there are some people who are in the midst of training are kind of using ultrasound to see what it looks like, you know, on an easy fistula to cannulate. And so, you know, that's another way to get experience. So, and here, Dr. Nignard, here, one of the nephrologists at Emory, is very ultrasound savvy, doing, because I've been in the vascular lab, we kind of joined up together. And she actually took on the process of training ultrasound, but now our expert cannulators have enough experience that they can do it too.
That's really amazing work, and we're very interested in forwarding this thought throughout our dialysis facilities is a better way to have more communication with the vascular surgeons and right at the time of immediate need. And I think that's really important. One of the nurses says, as a nurse, we use it often, but the surgeon doesn't see what we see. So, you know, we need to make sure. They wanted to know how they could get that coordinated better. So
that's the telehealth piece of it. So if you know, and frankly, I don't even, we use the iPhones a lot, you know, so you just turn your iPhone on. Here's what the ultrasound looks like. What do you think about this? Or, and ultrasounds are all computers. You can save things and send the images, you know, over to the surgeon, and say, well, what do you think about it? You know, and I have some pretty astonishing ultrasound images of pseudoaneurysms and things like that from posterior wall punctures. You know, that if you ever saw that or saw, you know, pseudoaneurysms or things like that on your ultrasound and you sent that to a surgeon, you would stop them in their track for sure and say, you better get that patient over. So I think this is great. You know, pictures are worth 1,000 words. And then, so if you see something on your Sono site, you know, just take a picture or save it, and you know you can send it off. And as long as there's no patient information attached to it, and I think that's okay, HIPAA-wise. We're careful about not, you know, if you do it in telehealth, then that's protected information anyway. And so we're not worried about that. And I think you need to be a little bit careful about text messaging, images, and things like that. But within systems, I think that's HIPAA protected. So as long as you're assured of that, then you should think about sharing your images.
Well, thank you very much. I can't appreciate enough how much time you spent with the network staff to try to develop this so that we could share this interesting piece with so many people. And we will probably just ask you for a follow-up in a little bit after you get some more of your data and let us know how it's all coming about. It's interesting work and we're looking forward to it. And thank you very much.
Thank you. I appreciate your invitation to be here.
Thank you. I'm going to turn it over to Aisha.
Next slide. Hi, so I'm Aisha Edmondson, and we're going to be talking about decreasing COVID-19 hospitalizations and vaccination best practices. Next slide. So increasing vaccination rates for our COVID-19, CMS wants 80% of patients and 100% of staff to be fully vaccinated with the primary series. For COVID-19 hospitalizations, we are asked to achieve a 25% decrease from the previous year. For influenza, CMS would like us to get 90% of our patients vaccinated annually and 90% of our dialysis staff. And for pneumonia, there's a PCV 13, 10% increase of patients receiving from baseline in the option year one. PPSV 23, we would like to see 90% of the patients over 65 receiving. And for the PPSV booster, a 20% increase from baseline and patients receiving boosters. Next slide, please. As we all know, the network uses data to help provide technical assistance, interventions, and resources to help facilities facilitate these goals. And to ensure you receive the credit you deserve, we communicate on remembering to document your vaccinations in EQRS as well as NHSN. And the network continues to guide facilities into IPRO Learn, so our vaccination rate toolkits and our COVID-19 toolkits to help provide educational resources as well as current information about vaccination. IPRO Learn has resources focused on new documentation guidelines as well as up-to-date vaccination definitions in the event a facility was not able to join any of the recent CDC calls. We are here to support you guys. We also have resources to help patients understand why it's important to be vaccinated, such as our Get the Vaccines You Need, which is currently being rebranded to also include COVID-19, and the My Vaccination booklet that helps patients keep track of the vaccinations they received and a visual for what's recommended for dialysis patients. Next slide, please. The network also provides resources focused on educating facilities on preventative measures to reduce the spread of COVID-19, flu, and pneumonia, which then helps reduce hospitalization rates as well. Like the dialysis audit tool, environmental service disinfections that's been provided for each individual network, as well as the dialysis tool, hand hygiene, and hand sanitizer. Facilities can actually incorporate their PFRs to help utilize these resources to perform these audits. Next slide, please. So the methods such as reach, effectiveness, adoption, implementation, and maintenance may be used to better assess the impact to these interventions at both the individual and the organizational level. Promoting vaccines within the workplace, assisting in the efforts of vaccination champions and leads have also been deemed as best practices within facilities. Also, understanding why patients refuse to get vaccinated is important. The first step to addressing misinformation about vaccines in your population is learning more about it, including where it starts, when, why, and how it's spreading and evolving. Catching misinformation early can help you develop and get out accurate information to address the concerns and questions ahead of time and close information gaps before they are filled with inaccurate information. So we provided new things to know to promote vaccinations. Do you have patients who have refused the first primary series of the COVID-19 vaccine? Why not offer them the new vaccine Novavax, which is created with the protein subunit vaccine technology, which is well known and established platform that as other vaccines such as seasonal flu and whooping cough. These platforms can stimulate an immune response without actual exposure to the virus. or are COVID cases on the rise in your clinic? The Omicron subvariants BA4 and BA5 are behind an increase in COVID-19 infections and hospitalizations. And the updated COVID-19 bivalent vaccines are formulated to better protect against the most recent circulating COVID-19 variants. And they also restore protection that has weaned off since the previous vaccines and were designed to provide a broader protection for newer variants that may come. Search for these authorized boosters in locations near you. Also, are folks unsure about when to get the influenza or the additional COVID bivalent vaccine? They can actually get both vaccines at the same time. They just have to have completed their primary series over a 2-month period before they are able to get the bivalent vaccine. And we all know September and October are the best times to be vaccinated against viruses like flu and COVID. So everybody must work together to get those patients vaccinated. Next slide, please. So with that being said, I would like to introduce my speaker, Renata Kozier, who has been working in dialysis for 9 years and became a charge nurse 3 years ago. And with all the current challenges facilities are facing, she still loves dialysis. Renata.
Hi there. Thank you for the introduction. Again, my name is Renata. I'm the charge nurse 2 of the Framingham Dialysis Clinic in Massachusetts. Currently, our census is 123 patients, and our vaccine rates up to date right now for COVID-19, we have 95% patients vaccinated. 117 patients are vaccinated. 104 of our patients have additional doses. We only have 3 patients that have declined. Our influenza rates are 98% of our patients are vaccinated, and I can tell you only 1 has denied the flu vaccine every single year for religious reasons. For our pneumococcal vaccines, 97% are vaccinated for Pneumovax 23. Okay, next slide, please. So what our goal is to make sure that all of our patients are vaccinated against everything that we can offer within the facility. We wanted to develop a process where every single patient that we currently have is captured, and then an ongoing process where every new admission, we have a new admission checklist, and within that checklist, we include vaccines. So we offer them right away, or if they've received them elsewhere, we make sure we get that documentation right away. And then on a ongoing monthly, we have a review of all of our vaccines just to make sure nothing slipped through the cracks. When we have a vaccine coming up, for example, flu is going to be coming up, we make a few days for flu vaccine days. We do a flu clinic. So we start hanging up posters ahead of time. We prepare the patients, we prepare the staff with all information regarding whichever vaccine we're going to be administering, and we get as much information covered as we can beforehand. Next slide, please. So we create a process which is a team approach where we educate, bring awareness, and communicate with all of our patients. If, for example, a patient refuses to have a vaccine on that very first initial contact with a staff member, we let them sit on it. We provide more information about the vaccine, and then on the day of administration, we approach them again. Usually a nurse will talk to them. If they still decline and don't want to be vaccinated, we then put the social worker to work and have them talk to the patient. And if after the social worker, the patient still declines, we have our medical director speak with the patient. So it's an interdisciplinary team approach to make sure that the patient is educated as best as they can. They have the most exposure to know pros and cons of getting vaccinated. We hang posters throughout our lobby, every contact point that the patient comes into in the lobby, at the scale, at all of our sinks. Whenever we're going to be doing vaccine days, you know about it the second you walk into our clinic. There's information about the vaccine everywhere. Then, you know, a lot of patients are nervous. We let them think about it, but we always revisit it within a, you know, usually a week. We revisit it. At care plan meetings, we revisit vaccines with every patient. That's a good way to capture anything as well. Next slide, please. So like I had just said, I got ahead of myself. We like to educate everyone through an interdisciplinary team approach. We want to make sure that everyone has all of the information. We always give out the VIS for every single vaccine. We always want to make sure that our techs, our nurses, even our administrative assistant are all on board when it comes to having the most up-to-date information so they can better answer questions that patients may have. Next slide, please. So this goes into effect mostly for the flu and the COVID vaccines that we were doing for the first and second series that we were giving. The boosters are on an as-needed basis. But like I said, we set 2 days aside to prepare for this. We print out the VIS, we print out patient consents, we even print out patient administration records, so everything can be in line, in place, and organized. And then the day of, when we're ready to start giving vaccines, it's all hands on deck. All the nurses are giving vaccines, all the nurses know how to enter in orders, document the orders properly, as well as fill out the administration records for the patient, answer any questions that they have. So it's not just one person doing all of the administration of the vaccines. And then if there are patients who, you know, initially, if there are patients that say, oh, yes, I do want to get it, and then the day of the vaccine, they say, oh, you know, I actually got it at my doctor's office. We certainly follow up with that too. We've had some patients say that and not actually be vaccinated. So we call doctor's offices. We have access to our Massachusetts immunization site where we can get that information if they have been vaccinated elsewhere. That way we can document it. We want to make sure those patients are captured and they get the credit that they've done the work, that they have gotten vaccinated, even if it's elsewhere. We don't really care. We just want to make sure that they're vaccinated and protected. As for booster shots, we did receive the booster vaccines within our clinic. It was a little delayed though, so some of our patients were able to get those boosters elsewhere. When we were ready to give out those vaccines, again, it was the same approach. We talked about it beforehand, we got consents beforehand, and a bunch of our patients did get it elsewhere, but they were able to provide that documentation to us. Next slide, please. And I think I saw a question come up in this.
Yes, so Vicky Cash says, unfortunately, there's no way to print patients' med lists for vaccines from EQRS. Most EMRs will show vaccination dates on the patient's medication list. I believe that's the question.
Correct.
Sorry.
No, sorry, go ahead.
No, I was also asking you, Renita, if you were getting that bivalent. There was a question in the chat that I answered before that asked about EQRS, but I was curious if you've gotten the bivalent vaccine in to give patients yet.
We have not yet. No, we did get a large shipment a few weeks ago of just another booster dose, and then the bivalent vaccine became available, but we have not received those at the clinic yet.
Do you think you will? Is that like going to be something that comes available?
I would hope so. That seems to be the way that everything is going now. That's the recommendation. So I would hope within the next few weeks we do receive it, so that way we can hopefully plan it out with the flu vaccine.
The other question I had is what pneumonia vaccine are you guys giving? Are you giving 15 or 20 or 23?
So we have 23, as well as we just received 20.
Okay. Yeah, our recommendations are a little out of date with the 13, so we're hoping the CMS takes those goals away, because I know you're not giving that. So you're going to primarily go to giving 20.
That is our new standard. Yeah, we just started that, I think, a month ago. they're still rolling out with the new guidelines for it and how to transition patients, because the 23 is, for right now, we want to give that to everyone. And then we phased out 13 and replaced it with 20.
Do you have any tricks of the trade, how you keep track of all these, you know, the pneumonia, since it's 5 years, and if you had this, then it's that? I mean, is there anything you can share with us? Because it gets a little complicated to keep track
It
of
does,
all.
and it does get very complicated. And I know our company now has, like Fresenius does have a tracker that you can pull vaccines and it gives you recommendations, but I'm a very visual learner. So I've created my own spreadsheet. It took some time to create that initial one with all of our patients, and it's easy to keep track now. Whenever we have new patients come in, I just add it, and it's so if you do a big widespread sweep of all of your patients and everyone is currently up to date, that can just be a quarterly thing where you go through and you know someone's coming due within the next few months, someone is no longer eligible for it for whatever reason. Because it's every 5 years, that's something that's a little more tangible. But I have created my own spreadsheet.
That is amazing. So you have like your own tracker.
I do, yep.
I think that's a best practice there, Aisha, right?
Yeah, I agree.
Think so. I think so. I think you have to figure out what works best for your clinic, for the modality that you have, for the type of clinic you have, for the size, for which, the staffing that you have. I know staffing is a big issue in a lot of clinics and locations, but if someone can just take charge of vaccines and make sure that everything is all set. I have helped out at clinics where they don't have a charge nurse, where they've had a lot of travel nurses. What ends up happening is every patient needs to have a care plan every single year. And so you give the nurses primary patients, and when they're due for a care plan, you review your vaccines. You have to. So if someone's due for a vaccine within that year, you just administer it then, specifically the pneumonia one.
Do you encourage your patients to carry their own records? You know, the booklet we have online really is a nice one because it tells you everything. I never knew as an adult, you know, for my kids, I carried my booklets everywhere, right? I knew what they needed. But as an adult, it really kind of makes sense to have your own booklet too. Do you encourage your patients to carry anything around about what they've had or had not?
So this is the first I'm hearing of a vaccine booklet, and I would love to see more about that. Again, the COVID vaccine is the only thing that I've ever even seen with records that they carry around with them. Knowing that there is a booklet, I think that would be very beneficial to the majority of our patients. I mean, some of them don't even remember what they had for breakfast in the morning. So if we can help them somehow keep track of their vaccines, that they can bring to their primary care appointments, since we don't offer every vaccine that PCPs encourage or anyone, I would highly encourage that. Yes. And I would love to see more information on that, if that's something that we can adopt.
Oh yeah, it's a generic booklet. It has every vaccine that a patient could use, you know, especially ESRD. We've written it for all ESRD. So it has zoster, it has all the boosters that they should consider.
That's
And
great.
did we have to update that one, or is it currently updated with the COVID in it?
So the booklet actually has COVID in it already.
Okay, good. So it's ready. So we can give you the link for that. It's a little bit of a print job. You know, you can print it black and white scale, but it's a couple pages to print it off. But I think it's a foldable format that you can just make it into booklets. But it has everything they should consider. I'm actually thinking about using one myself.
That's great.
If a patient is over 5 years with 13, are you now giving the 20?
I need to look more into that. We have not rolled out 20 yet within our clinic. We need to have our medical director on board and do a big governing body on the new policies that have come out. So I can certainly update once we figure that out, but hopefully at our next month's meeting, we'll be rolling it out and come up with a final plan.
I don't know if Aisha, you could put the booklet. I see another request for the booklet. I don't know if you could put the link even in the chat.
Sure.
That would help. Yeah, I don't see any other questions. I was trying to.
They say, Shannon, I believe, are they going to change the requirements then to 20? I am working to get everyone up to date on 13 and 23, and I don't want to do all of this and have it change again to convince the patients to get another vaccine. So currently, the statement of work, our goal is to get patients vaccinated against PCV 13 and PPSV 23. So we are abiding by our contract to get patients, but we also are communicating to facilities that the focus is that we want patients to get a pneumococcal vaccine, in whichever manner that may be, and EQRS has been updated to also be able to obtain that information. So hopefully, again, like we previously stated, there's a modification to the statement of work and it'll align with the CDC recommendations. But currently, as of right now, those are what we're aiming for.
But as a clinic, I would go with the CDC recommendations, quite frankly. That's what we're gonna end up being. So if you're in a clinic, they are saying now that 13 really is no longer recommended for patients, that they should start with something 15 or higher, and really 20 or 23 is the way to go. What I'm reading from CDC is if you've had 13 within a year, you should get a 20 shot, and then every 5 years after that, either the 20 or 23. So, and the frequency they're very unclear about, like whether it used to be 2 or 3 in a lifetime, but it sounds like immunocompromised people could get it more frequently. Maybe if they were 60, they could be getting it more than that. So I think they have to check with their doctor about whether they only get 2 boosters or will need more than 2 boosters when it comes to pneumonia. But definitely the 13 for our population is going by the wayside. So if I were the lady who was writing here, Aisha, I would tell the lady that don't work on your 13s. Try to get everybody 20 or higher at this point. And if they've gotten 13, try to get them a 20 within that year of getting it.
I put the link to the vaccine booklet in the chat, and I also provided both the English and Spanish version of all the vaccines that you need. It's a trifold for patients to see what adult vaccines they should be considering.
That is the one, though, Deb, we don't have COVID on yet. I think.
Right, so we're rebranding that one. That one will be updated.
At least it's in the vaccine booklet, but the other one is still valuable for flu and pneumococcal and
hepatitis B.
How did you set up your tracker, Renita? Was that just the patient names and then you put like the dates and what they got, and is it just kind of that simple, and you're trying to keep track of what they have and what they're going to get next? And
Exactly. I have patients' names, medical record number, date of birth, their admission date, and then the date that they received their first Pneumovax 23, when they're due for their next dose. And then I highlight it kind of, green means that they're going to be upcoming within the next year. A different color if they're not for a few years from now, red if they're over the age of 65 and they're all set. And then the same thing with the COVID vaccines.
awesome.
That is great.
Any other questions?
Dr. Henner commented that with travel being such a burden and barrier for our patients to get vaccines, that we should all try to, whenever possible, administer additional doses, including the bivalent, at dialysis facilities.
Absolutely.
So does anyone else have any other questions for Renata?
There's a question in the chat, Aisha.
Am I missing it? Oh, so if they have had 13 and 23, are they done since over 65?
Yes, from my understanding, yes. But now with the 20 coming out, I believe that we should be vaccinating them with 20. But again, I'm not exactly sure on all of the specifics for 20 yet.
I would recommend following the formulary and the policy of your organization and governing body.
Agreed. Thank you so much, Renata, for your time.
Thank you.
Thank you. And with that, I guess we're going to conclude this program. It's been a very, very wonderful session. We thank our speakers, Renata and Vicky, for joining us today. And we are going to be following up next week with our next best practices call. And we look forward to seeing you all there as well. Thank you very much and have a great day.
Thank you.
At the conclusion of this, when you exit your meeting, you will see a survey pop up, and we would appreciate you take a couple of minutes to fill out that survey so we can better prepare these for you in the future.